A very good afternoon to all, and thanks for this opportunity. I shall be talking on endogenous endophthalmitis of the newborn. I'll start with this case. This is a 1-month-old baby boy who presented to our outpatient department accompanied by mother for ophthalmic evaluation following septicemia. This baby was a product of non-consanguineous marriage, and gestational age was 36 weeks, postmenstrual age was 40 weeks, birth weight was 1.6 kg, and there was a history of NICU stay for 1 week. And baby was still in NICU, and the pediatrician had sent with the NICU nurses to the OPD. And in NICU, he was diagnosed to have fungal urosepsis and staphylococcus bloodstream infection and was started on intravenous antibiotics and antifungals. This was the baby, and when we saw under microscope, anterior segment was essentially within normal limits except mild congestion in both eyes. And this was the fundus picture. This is the red cam picture of right eye and left eye. There was vitritis present in both eyes, and there was yellowish fluffy exudate sitting on the retina in multiple areas in the right eye as well as in the left eye. The left eye fluffy exudate was very prominent, and it was protruding towards the vitreous cavity. We diagnosed fungal endogenous endophthalmitis in both eyes, and we planned vitreous biopsy and intraocular antibiotic in the right eye. And for the left eye, we planned for pars plana vitrectomy, vitreous biopsy, intraocular antibiotic. So this was a 25 case trocar cannula system, and the right eye actually was operated. It was not a pars plana vitrectomy, it was a vitreous biopsy because the affection was very localized and minimal. And for the left eye, we did a minimal pars plana vitrectomy, and we did a localized PVD around surrounding the exudate sitting on the macula, and the entire exudate, it came out nicely, and and then we closed the sutures, ports with sutures. The right eye did not reveal any organism, and the left eye revealed Candida albicans. And the next plan was to inject intravitreal antifungal. Amphotericin was injected 10 doses in the right eye and left eye in NICU itself. This is the red cam picture after the second dose. You can see there were a lot of exudate here, and it was literally worsening in both eyes. Here new exudates appeared, and in the left eye also the exudate didn't go after third dose as well, and you can see now it is very prominent. And so we kept on injecting, and these are the serial red cam pictures of both eyes, and finally it started responding well. And this is the fundus picture after 10th dose of Elamfo, and you can see the scarring has started in the left eye, and this is a picture after the 11th dose. And the baby came after 1 month of post-injection to the OPD, and we could take a fundus picture with Zeiss Claros, and this was the picture. You can see there was parafoveal scarring in the right eye, and the left eye there was scarring sitting on the macula, and there was no sign of active inflammation or infection. And this was the OCT picture in the right eye. It was normal, and the left eye, you can see there was outer retina damage with foveal atrophy corresponding to the macular scar. We analyzed the clinical and microbiological data of clinically diagnosed patients of neonatal endogenous endophthalmitis from April 2013 to January 2023 at 4 tertiary eye care centers in 3 neighboring states of India. The detail of the study I am not going to present. It will come as a paper. What we saw, there was definite systemic associations like vaginal delivery and ICU care, oxygen therapy, intravenous drug use in NICU, and broad spectrum antibiotic use before developing endogenous endophthalmitis. Typical presentation was conjunctival congestion, cloudy cornea, anterior chamber exudates with no fundus view, but we also saw a couple of cases with white eyes, no conjunctival congestion. 40 eyes had clear cornea, 19 clear lenses, 12 presented with lens abscess, and 7 presented with retinal detachment, and 4 with choroidal thickening. The commonest organism was Pseudomonas aeruginosa. We also found fungi as well as gram-positive cocci in the culture, and the culture yield is very less. It was 40%. The prognosis was poor, with 50% of eyes going to thysis bulbi and the rest with maculous scar sequelae. So it's very important to advise amblyopia therapy in these cases. If the baby presents, one eye is affected and you are doing a vitrectomy, there is high chance of eyeball elongation if you remove vitreous from a neonate. So these patients, those babies to be followed regularly, and myopia is a rule if you have done a vitrectomy. A minimal vitrectomy, that's what we have started doing in these babies. Thank you.
Thank you, Dr. Sameera.
Okay, yeah. No, carry on. My only query was that was the vitrectomy really required? You see, a 1-day-old child and you see that fungal granuloma, we could have tried this fungicidal drugs. Ultimately, amphotericin B is the drug which ultimately cured, and baby was quite lucky that he responded.
Yeah.
Not all fungi respond so well. You see, despite amphotericin, despite all these azole drugs, I could have tried,
I have, yes, yeah. That's a very good question. We actually look at our series of neonatal endogenous endophthalmitis. We realized those babies who received only systemic antibiotics or antifungal agents, or they received only vitreous biopsy, not vitrectomy, then they did very poorly. And 80% of them went to phthisis, or almost nil, with nil visual prognosis. So we have actually switched to protocol-based treatment for these babies, and we are doing a good vitrectomy. We are trying to remove the exudate, whatever possible, and with intraocular antibiotics or antifungals. So that's why we kept on injecting, as well as we did a good vitrectomy in both eyes.
That's perfectly okay. Post-op management was fantastic. You kept on injecting. I think that is what saved, ultimately eradicated the fungus from the eye. But a lot of these patients with fungal are recalcitrant despite
yes, true.
Also, was it necessary to do the invasive procedures in both eyes? Since you were already going in with vitrectomy, what was the need for biopsy in the other eye?
Yeah, that's a very good question. This baby was already diagnosed with fungal urosepsis as well as bacterial septicemia. In the blood, they have, there are culture positive blood culture was yielding some bacteria, and the urine culture was yielding fungus. So we wanted to, we didn't think that both the eyes are having similar organism. So that's why I did both eyes biopsy.
See, the thing is, it's a one-day-old baby.
It's it's 1 month old baby.
1 month old baby, okay. The lesion is classic of fungal endophthalmitis. The focus is very small, okay. And the yield of the organism can be best from the left eye, not from the right eye, because the lesions are very, very tiny in right eye. Left eye, it is a definitive, a small lesion popping into the vitreous. I would have done a single port aspiration biopsy of that lesion.
in left eye.
In left eye.
In left eye.
Yes. And then
Nothing there.
reconfirm. Though clinically I am sure that 80% this is fungal. The very first slide we said it is fungal endophthalmitis, which would have saved the complications of vitrectomy in a neonate. If it is not neonate, you have done in an adult, the questions will not arise so many.
Sameera, the other thing is,
Yes, the point well taken.
1 second, thinking of two things in two eyes. You see, even if you have to take biopsy, one eye is good enough, na? Why are you thinking that this organism will be different and this will be different in endogenous?
Yes, point well taken, but it's very difficult to have a geo clearance again. So that's why I.
In any case, we can keep
So
arguing.
at that point, I thought that would be the
We
best.
agree with you. That is the point. Okay. Thank
Anybody,
you very
anybody,
much,
anybody
Sameera.
from the audience
No,
would
no,
have
no.
done
Let us not
differently.
make it more controversial. We will move with Dr. Srinivas Jose.
No, it's a learning exercise
Yeah,
for
ठीक है,
everybody. It's
okay,
a learning
okay.
exercise.
Throw
Because
the-
time is only one talk is left.
Yeah. Okay.
She's a brave.
Heroic, yeah.
But excellently, ultimately, you see, whatever God does is good. Both eyes are doing well, so we are happy.
Yes.
Thank you.
With the outcome, we are very happy.
And it's very important to not only to get a positive result in microbiology, it's important to to remove the exudate,
The only
because
difference- the only
fungal
difference
sometimes
we-
increases with time. Even if you inject, sometimes the exudate increases. So that's why I wanted to take out the entire exudate from the right eye as well, so that it will not spread much. So that was also one thought behind this.
Yes, Srinivas, are you ready?
Thank you, Dr.
30 seconds.
Sameera. Thanks.
Thank you.
But the reason we asked Sameera was just to excite some discussion, because I may not have done biopsy in both the eyes. I would have done biopsy in one eye. And other thing is, I do not believe in this concept of minimal vitrectomy. Once inside, do a total vitrectomy.
मुश्किल है. Especially when there's so much localizing lesion.
Do a complete vitrectomy in a newborn, because we do ROP surgeries and we have seen, and there is elongation of the eye,
Eyeball.
and it causes myopia, minus 20, minus 15, or sometimes minus 30. So a minimal vitrectomy we prefer if the infection is localized. If it is a diffuse one, definitely a good
Yeah.
vitrectomy. If it is a localized one, we try to focus that area.